hear from you. How are you doing on time, Sophia?
Oh, hello, nice to see everyone. I can only jump in for about 20 minutes, so I'll be headed off in a little bit, but happy to jump on and just see some friendly faces and listen to everyone. So
Get you on in a second. Just want to know there's a couple of things I do want to address early on. Anybody else have a time limitation? How are you doing, Mick? Because I want to hear about what's happening in Ireland. Anything, Mick, how are you doing in time? Are you okay?
Time is fine, Paul. I just didn't want to delay you more.
Yeah, okay, got it. And then Mike Levy, how about you? Anything time okay?
Well, I have to be off at the top of the hour. Thank you.
Good. So we'll try to get to you early on as well. That's what I was asking. Anybody else? And then Doug, are you prepared to at least introduce one of the things that you want to bring up as a topic at Eagles that I've written in here, in terms of looking at, the pros and cons of giving drugs for bugs, right? Are you prepared to at least intro it to us?
I'm prepared with no data or that sort of thing at this point, but certainly we have some significant experience with it, and I'm happy to introduce it. I Mike, I have to be off by the top of the hour.
All right, I may just get to you guys early on and mostly I want to introduce the topic. That's all. And that because we're just talking about some of the things we're going to talk about, and it gives people, so they're not caught off guard at the meeting. They're thinking about it ahead of time and some of the things they're going to want to mention. So, okay. So let's go ahead and get started. First, I guess the best thing to do is, how are you doing on time yourself, Candace? I see you're on. Candace, are you there? Panetta?
Yes, sir, I'm here.
So how are you doing on time? Could I let some of these other folks on first, or can you towards
Absolutely, no. Get going with information and I'll hang out for when you're ready.
Okay, good. Thank you so much for helping us. She's going to help talk about the meeting coming up in June. So I just wanted to give you guys some preliminary instructions about that. Okay, so with that. All right, so let's now start off with Sophia Dyer, because we're just glad one of the reasons why we switched to this hour is to be able to get her on, because she's always busy on Tuesday mornings. And so, and she turns out now they've started up a new thing where she's going to be busy on Tuesday afternoons as well. But we don't care. We're glad to have you for a few minutes. Okay, so what's happening in Boston and what's happening with you? Okay.
yeah, so thanks. And again, nice to see everybody. I know everyone's also busy with competing meetings and everything, but things in Boston are great. They're really good. We're having pretty good weather, had kind of a mild winter, not as much snow as we usually do. So all that is good. We are have been launching into the MIH world, which is a little different in Massachusetts. So that's actually kind of fun stuff.
Why is it different there? What makes it different?
Well, I think we are, we have a lot of other kind of regulations and governance and stuff like that, not unlike other states as well. So we're kind of mostly focusing on mental health populations and substance use and stuff. So yeah, those things are good, and I look forward to seeing everyone in Florida. So I'll be able to make it out this year. So good stuff.
Yeah, it was just too bad about the conflict last year. And so, but a lot of us are going to be there this year that couldn't make it last year. So it's really exciting. It's going to be
last year I had the opportunity to do the Harvard NPLI program, which was absolutely fabulous. If you ever have a chance to do it, it was definitely a good one. So
now you got the Boston Marathon coming up in just not too long from now, actually. And so is there anything that you guys are doing differently in the last couple of years than you did, say, when you had the event? Because it was interesting for anyone who didn't know that at the Eagles meeting that year, when the Boston Marathon bombing happened, we had a whole presentation about one was from Super Bowl Sunday to Fat Tuesday,
yeah.
We went through all those different scenarios of different things and how people were preparing for them places. And one of the things was about Boston and the marathon. What do we call it? In it for the long run, right?
Yeah.
And it was really cute. And then but she got in and talked about there could be bombings and how they had dogs there and everything that did play out. And is there anything that you're doing differently now that that you'd make it even better because you guys did a pretty good job overall.
Yeah, well, I mean, we always kind of go over different iterations. We had a little pause for 1 year for COVID, but we're really kind of embracing a lot of the virtual teaching and training. I think EMS has kind of gone in that direction a lot more since the pandemic. And so, we used to have kind of in-person big meetings, and now we're actually working with a production company to get all of our education programs so that all of our doctors and nurses, who are fabulous volunteers, get all that done.
Yeah.
And so they really understand the protocols, the hyperthermia, the hyponatremia, the cardiac arrest protocols. We're still doing a lot of bystander CPR training. It's going to be part of our expo that's
good.
going to be happening. So we're actually really excited about that. That's supported by the great folks at Mass General. As well, as some of you might recall, we actually did have a young racer who had a primary cardiac arrest, thankfully near responders, and got some great first responder CPR and AED applied and made a full recovery. So we were so grateful for everyone participating in that. So we're just kind of continuing all on that vein. So I'll tell you about it after it's done.
Yeah. One of the things just remind me of something, because it was similar to what you guys have done in preparation, is taking one of the things is that when people do planning for different events, they may have a scenario that everybody sort of reacts to. But what I thought was kind of cool was when I went out with the folks in Las Vegas when they're preparing for Electric Daisy Carnival, is that they actually had 5 or 6 scenarios where they had each sector, like the hospital sector or the police sector or the transportation sector, doing different problems with them. So everybody gets familiar with each other, because that's, I think, the single most important thing I found in disasters is that the people who are there and what their organization is and who fits in what food chain ahead of time. So again, you guys have done something along those lines. So I just wanted to
Similar as well. Yeah.
bring that out. Okay. All right. So let's move on then. Okay. Thank you for being here. We'll try to do it. Sandy, how are you doing? Sandy Schneider, how are you doing on time today?
I'm fine.
Good. All right, then let's go to Mike then, since you got to get it. And then Zita, how long can you stay on for? Because I want to introduce you. Okay.
I have until 1.
Okay, you do. Okay, then maybe I should introduce you now. And someone I need to introduce you to is Dr. Augustine, who takes down all the demographics about your service and so on. But I was really pleased that we got you on board, because you cover Alameda County, which includes Oakland, and it's really great to have a representative from there. So if you don't mind, just come on, say hi to us all. And this is let's say your counterparts out in all the other larger cities in the country, and some other folks that, Dr. Schneider is our senior vice president for clinical affairs over there at the American College of Emergency Physicians, or various representatives from other organizations such as GAM from NHTSA, et cetera. So you'll have some really cool people that are on this call, and a bunch of others that we'll introduce you. So just tell us, if you give me like a 30 second to 1 minute version of what you do, what you cover, and how many people you got in your jurisdiction, and then you're welcome to be on board with it as much as you can. Okay.
Okay, wonderful. Hi, everybody. Thank you for inviting me. I'm quite excited to meet you all at some point. I'm Zita Connick. I took over Alameda County from Carl Sporer, though I'm trying to keep him on forever, indefinitely, trying to talk him into it. He is going to stay.
He took your place up in
He
Napa.
did. Yeah, it was not intentional. It was not intentional. Yeah, I had Napa before, and then I came over here, and yes, he has taken over soon to be in Napa. So we did a little job swap. I am excited. This is so Alameda County, of course, includes Oakland and many other large cities. The total catchment's about 1.8 million people. And I'm really just trying to get schooled up in the policies here, getting to know the politics, et cetera. It's a little bit bigger than Napa and just a tad different demographically. So a little bit of different challenges. I have some ideas of what I'd like to do, but I need to get to know everybody first. So
yeah. And then the other thing is we can help you. I mean, there's a lot of models out here. We're very fortunate to have the Deputy Secretary of Health for the state of Florida on board, Dr. Ken Shepke. And Ken Shepke always credits Mike Levy, who I'm about to call on, but we say that we have the biggest R&D department in the world, rip off and duplicate. So we just borrow from each other, and that all came out. Yeah. So And by the way, this organization is no organization. We have no dues, we have no officers, we have nothing. We're just who we are, okay? And we like to get on, so it's really a safe zone. Everybody's smart, no one's smarter than anybody else. We just get on and help each other out. That's the whole philosophy here. And then we're going to be meeting, and we hope you will be able to join us for a week down in Fort Lauderdale area at the Hard Rock Cafe in Hollywood, Florida. We'll be doing that the week of June 12th. And so most people fly in on the 12th, in time for dinner, and then we're there 2 days. We just have a closed conclave with ourselves, and then we actually have a fellows day where most of the fellows from around the country will be there for both of those days, but we focus on them on day 2. And then on Thursday and Friday, we have a big national meeting where we give about 100 presentations in 2 days, and it's unbelievably cool. So it really is good. So, okay, quickie, and we'll talk later. Hopefully you can give me a call tomorrow or the next day, and we can catch up a little bit. Okay, but thanks for being on
That'd
board
be
here.
great. Thank you.
Okay, Mike Levy is not only our immediate past president of NAMSP, but he has the Anchorage area and the state of Alaska, as a matter of fact. Just a couple little things that he does, right? So Mike, anything to report out of Alaska or NAMSP, since I didn't see Jose on today?
Real quick, thanks, Paul. It's really great to see everybody as usual. It's almost like being there, but not quite. Paul, you said there's no dues. Is that DO or DUES with regard to the organization?
Dues and don'ts, right? No, but my point is that we have no hierarchy or committees on this or that. We're just us helping each other out, and so that's all it is. But go ahead and tell us about the do's and don'ts. Your point of view, Mike.
Well, real quickly, I asked and had the help of Stein and Mr. Maldonado to try to get a survey out to folks. I'm just curious if folks have kind of no-fly orders for ground ambulance like we do for air. I'm trying to prepare something on that, as well as my own agencies, having seen line of duty deaths associated with traveling in bad weather and the like. So interested what folks have to say that. We can do that offline, of course, on that poll if people are able to respond.
Or you could talk to Mick Malloy, right? Which
Yeah. One thing else I'd mention, this might be a topic for Eagles, is just this idea of legislating EMS, and you still see a lot of stuff popping up. Illinois right now has a couple of things that are of concern. They're still just bills. So House Bill 1595, even after I think 1595, I'm sorry, I get 1595 and Senate Bill 1306. So 1595 is has to do with even after due process, and they have a very strong due process system there after the medical directors reviewed some type of problem with an EMS provider. The bill then advocates or requires that the person have this go into arbitration with union representation and the like, or just other people outside of the medical sphere to arbitrate this further, which of course raises concerns about where we fit in this process. I think that one really bears watching if it goes anywhere. There's a separate one that I think is kind of interesting. That's Senate Bill 1306. These are just, again, state bills, but this is talking about mandating body cams and has some for EMS, and has some language around it about how you would do it, how long you preserve the documents and the like. So that's a controversial subject, whether or not we should or shouldn't have it. But again, when it gets mandated, it always raises concerns about unexpected consequences. So just trying to keep a few kind of things up in the front burner with that. So that's kind of an overview of a few things, Paul. I appreciate it. Oh, well, one last thing, I'm sorry. And this is many thanks to Sandra and to folks at ACEP, but we will be having the review course, the EMS board review course. It will be August 21st through 23rd. So arrive noon on the start on the noon, the 21st, and end on the morning of the 23rd. So certainly all fellows and other folks that are in line to want to take the written exam should consider that. That'll be in Dallas, Texas at the ACEP headquarters. Thanks again, Sandra, to you and your folks for hosting us there. You're our partners in this, and we appreciate that. Thank you.
Great. I'm Mike Levy, and I approve this message. That's great. Okay, thank you, Mike. Appreciate it. Let's then move over quickly to Doug, who has to get off here pretty soon. Doug is our medical director from NAEMT. And Doug, you just want to tell us really quickly a little bit about what you want to maybe bring up at Eagles, and then I'm going to have Paul Banerjee be prepared to answer, and also Dr. Ken Shepke, because this is an area you guys have been involved in, and probably others as well on the phone. But go ahead, Doug.
Sure. This was of interest to me, and this came as one of the surveys that went around some questions about antibiotics for open fractures. And This was not developed directly by us. As a matter of fact, I think when Pennsylvania looked at a pilot for this, some of what Ken had done was some of the information we had, but most of it came actually from Mike in who's the medical director for Indiana there for a period, not anymore. They had done a nice pilot of, sort of proving the value of antibiotics for open fractures. And we used a lot of their data to start a pilot. The thing that was of most interest to me, and we can certainly share this with the group and present some of this at some point, but there are several studies that actually really show pretty clear improvement in soft tissue infections and osteo based upon the time that you get the IV antibiotics for open fractures. And East Trauma has a position statement on this. And generally, when you wait for people to get to a trauma center, there's some delay in getting the antibiotics. But heaven forbid they go to a community hospital, there might be a long delay before they get somebody thinks to give them IV antibiotics. Yeah. And so Pennsylvania did a pilot. It is sort of somewhere in transition to a statewide protocol, but it was a statewide pilot. And I can tell you that my own experience with my agency, as well as what I saw across the state, is that on average, and again, I don't have the numbers prepared but on average, it was probably about 35 to 40 minutes from the time of the 911 call to the infusion of antibiotics. And I really think this should be looked at as a time-sensitive illness, like we do STEMI and stroke and other things. I mean, it is time-sensitive in getting the antibiotics in, and if it waits more than an hour, more than 2 hours, et cetera, there's a linear increased chance of infections. So it's fairly simple, fairly inexpensive antibiotics used, and I think there's good evidence to say that it's a time-sensitive illness that EMS can.
Okay, Ken, who's our former state medical director of Florida and still has Palm Beach County and West Palm Beach, et cetera. Ken, you want to chime in? You got a second? You're now the Deputy Secretary of Health of the state, and is that do you think about these things?
I think Doug nailed it right on the head. Anything that's time sensitive, not just the antibiotics for open fracture, but just the way I view the world. Anything that's time sensitive, we have to get away from this idea that we only have X number of minutes of transport, as if arriving at the hospital equals arrival to treatment, because we all know that that's a fallacy. I mean, if you go to in case of trauma, you go to a trauma center, yeah, you have a whole team waiting for you. But there's so many time sensitive things where that efficiency is just simply not there for so many cases. So if it's something that you can handle with relative ease, relative low risk, and that's inexpensive, such as antibiotics open fracture, to me, this is just a no-brainer, common sense thing that improves the healthcare for the community. And when we look at studies, you can find a study that's for it, you can find a study that's against it. We know this, that the old adage, you ask 10 doctors their opinion, you get 10 different opinions. But it's the weight of the evidence, and certainly just simple logic with the exponential growth of bacteria over time, is that early antibiotics is going to be better than later antibiotics. And if it's simple enough for the medics to do, you should do it.
It kind of reminds me of the TXA thing, because if you give it late, then it doesn't make any difference. It actually may be harmful for you, right?
Right.
Here, I guess you could always have the option. And also, it should be, maybe it's something that you do study, just like we do at trauma centers. We look at outcomes or strokes, and we see what outcomes are if we elect not to give them in the field versus if we give in the field. I think the point that Doug brought up, which is that there's delays, are significant.
So now I don't have, I didn't know that you want to talk about this until today, or I would have gotten our numbers on this topic, but I already have the numbers on our septic shock protocol where we use pre-hospital antibiotics if they meet certain criteria. And we know the 911 to antibiotic time for the hospital when we started the study, they've gotten better, but when we started the study, it was 3 hours.
Yeah.
The 911 to antibiotics for us is 12 minutes.
See, that's exactly it. And then Paul, I want to come to you in a second, but I think what you just brought up is I think they did an audit also in the UK as well. Fiona, are you there? What can you tell us about that?
Yeah, thanks, Paul. So the BOAST and BAPRAS guidelines, which are the British Orthopaedic Association and the British Plastic Surgeons Association guidelines, have been for intravenous antibiotic comoxiclav for open fractures since 2016, and it's now nationally audited. I can't go back to the original evidence, but it's certainly pretty strong, and it's one of the audit criteria that the trauma audit national guidelines look at.
Okay. Paul Banerjee, you had some pushback when you were doing it for sepsis because they wanted to get blood cultures ahead of time and all that. Did you ever get any pushback on the open fractures part?
No, that was actually requested by the Department of Trauma. And because we gave Rocephin for sepsis, we just used 2 grams of Rocephin for open tip hip fractures. We've actually been doing that for about 4 years now. Mortality, length of stay is slightly better, not significantly better. But as Ken said, the earlier you get the medicine on board, the better it is that you can have outcomes for the patient.
Do we need to use this as a debate? Probably doesn't sound like it is for the Eagles, but maybe a presentation, a session on it that we would do and have all you guys do what you just did just now on the Thursday or Friday meeting, right?
Sure.
Okay, good.
No problem.
Anybody have a disagreement with that, or you want to go that route? Doug, how does that sound since you're leading this charge currently?
And Paul, I
Yeah.
would add TXA into this list, right? Because we know that the earlier the better for that drug too. So there's probably a slew of drugs we can add on to that.
Yeah. And then Peter, by the way, did you ever, I think they made a what's that called? A YouTube out of my presentation, right? Is that something we should send around to everybody? Would that be?
Yeah, I was just waiting for your green light on that.
Okay,
yeah.
got it.
Can
Well,
I
let
ask a question? So I agree with antibiotics, the sooner the better, less bacteria, although some EDs then repeat it because they say they'll be audited on it. But Peter brings up TXA. Peter, do you think it's in the same league as something as proven as post-open fracture antibiotics? I didn't think there was an American study in an urban center that showed benefit of TXA.
I'll send you my my video. You'll see. Okay, we'll leave it at that.
Well, other than a video, is there a peer-reviewed article from a large trauma center in the United States?
That's funny, huh? Okay, yes, there will be one soon. Okay, but listen, I want to move on to some other people, but I'll let you know.
Sorry, I hate when evidence gets in the way. My apologies.
Let me put it this way. I think it was, I can't remember exactly who it was, but it may have been Benjamin Franklin or something like that. Oh, actually, it was John Adams who said that, it's like facts are very stubborn things. You'll see. Okay. All right. Well, thanks a lot. Let's move on. There was somebody else that had to get off at, I think, at 11 or whatever, at top of the hour as well. I'm trying to remember who that was. But let's take advantage of this time. Was there someone else that had to get off at that time? I can't remember. Well, if not, just let me go over to Candace so I can let her free. Okay, Candace, you want to tell us about what they need to know or what we should discuss that's important? And by the way, Gam, are you okay time-wise to talk later?
I actually have to jump off too, Paul, sorry.
Okay, anything to report on NHTSA then for us?
Yeah, I'll keep it to 30 seconds. One, I know we've discussed with this group the ambulance chassis shortage before. The White House National Economic Council continues to meet with stakeholders on this issue. Best we've heard last, the major auto manufacturers such as Ford and others have increased their production. However, still experiencing issues with the ambulance manufacturers themselves and getting completed units out on the road. So always appreciate any input folks have on that. And then finally, what's called the triennial highway safety plans are due to NHTSA on July 1 is a new requirement of the bipartisan infrastructure law. The reason this is important for the EMS community is because post-crash care is a priority in the National Roadway Safety Strategy. So I encourage folks on the phone, if you haven't, to reach out to your respective state EMS director and encourage them to communicate with the State Highway Safety Office and ensure that post-crash care is included in this 3-year highway safety plan. There's a significant amount of funding associated with roughly a 50% increased highway safety funding across the country. That's it for me, Paul. Thank you.
Oh, thank you very much. I'm glad to have you on board as usual. So hope this has been interesting so far. Hey, so look, let's go ahead and get you on board, Candace. You want to tell us a little bit about the meeting and what we should do?
Sure. I'm dropping in the chat now that amazing website, the Cloud CME website, where you claim your credits either by app on their actual website, mhs.cloud/cme.com. is where I need each of you to log in. And actually, I can share my screen real quick.
That include me too.
That includes you too.
Okay.
On this main site right here on the bottom right, it says complete disclosure. So for all of you who will be joining us, whether Eagles Creek or Eagles Maine, you are all considered speakers. So I need you to log in and give me a disclosure, please, so that we can continue to give you CME credits for your time here. And that will really help us move along our application. And I know we've been talking about it, but we are 3 months and 4 days away from our Gathering of Eagles and First Air Force Care Conference. The website is up, the registration is open. So if you are planning to send fellows or staff, on the registration right there, it's got the prices and time. And it will give you right there the prices. I'm happy to send all that information for you, for anybody that needs it. There'll be an agenda and the link for your hotels. Everybody will be at the Hard Rock this year. So I will send you that link for anybody that is sending staff or needs that for planning purposes. We do have an official registration that will give you registration to Eagles Creek and Eagles Maine both. So we'll send that out through Dr. Pepe once we get the final list of who's invited to what.
Is there a discount for the fellows, by the way?
There is.
Okay, got it. All right, good. And that's in the registration there, right? Do they need a
Yes.
letter of proof or anything like that from somebody? Or are we just sort of taking it?
We have a special link for them. So as soon as you know that you're going to send fellows, let me know and we can send you that link.
And so two things. One is in your local areas, get the word out to your local EMS crews and other people about this meeting. That would be great. You can help us advertise it. Number two is that you make your plans right now to come. And then of course, we're going to use the same thing as if we don't make any money for some reason this year, we may be stuck with our own, but if there are, our own costs, but so far that has not been the case. It's been really, we've been able to take care of everyone so far. If there were some people that fell through the cracks, it's just because we didn't get their information, and there was one or two and we fixed it up later on. There are some people who absolutely have to have it funded, and there's some people who can get their funding done through their universities or other agencies. And that would be really helpful to everybody else, because we're going to try to bring in folks from overseas. Not only, we said last week with Pierre, Fiona, Mick, et cetera, but some others, even as far as ways from Australia, et cetera. So we just wanted to do whatever we can to get it going, getting the cheapest airfares you can get, et cetera. And look for you. And please stay as late as you can on Friday, because even if you stay into Saturday, because we like to have everybody there, especially towards the end of meetings and all that. And you never know when I'm going to be able to assign you to a talk, right? So, and because we have to all, piece it together. So that's it. All right. Anything else then you could think of, Candace?
That's it. Any questions for me about CME or the meeting?
I do have a question. I don't know. I haven't checked it for a week or two, but for a while I couldn't print out my CME certificates. Is that fixed now? That there was a glitch?
So we sent, thank you for reporting that you guys, it's on your transcript, but you may have not gotten the individual certificate emailed to you. We put in a report through the CME system, so that should be being fixed. So
Okay.
if you guys don't see that, or if you need the individual certificate, just reach out to me and we'll make sure you get that.
All right, fantastic then. All right, well, thank you so much. All right, and anybody else have to go pretty soon that I can get you on before things fade away? But Candace, as usual, remember it's like it's still we really thank you a lot. So God bless Candace, right, everyone? So we really appreciate you helping us out here and being a mother hen and all that kind of stuff. So so Candace, can you, if you can, find out how much they spent at that when we went to Anthony's that year, right? Or last year? I want to find out what the budget is. The reason why is that we're probably not going to be able to get into Anthony's this year, but I think we're going to go up to, we'll probably go to the Greek Isles. Well, and I'll tell you more about that later, but I just want to see what the budgets were before. Okay, so thanks a lot. It'll be cool. And I may figure out a cool place for us to go on Monday night as well. So especially we get someone who can sponsor it, because I'm going to try to get everybody in time for dinner. Okay. So, all right. Well, that's it at that end. All right, anybody else have some time limitations? Otherwise, I'll slip over to talk to Mick. I want to hear a little bit about what's happened at your place, because you're always reporting from Wexford, and you had kind of a little tragedy there, right? And tell us about the implications. David Perch, you're okay to stay on for a while, right? Because I want to talk to you as well.
Yep, I'm here.
Okay, good. Thanks. Go ahead, Mick.
So last Wednesday, 4 o'clock in the afternoon, busy day in the ED, one of the attendings walked into one of the rooms and said to one of the residents, "Oh, it's burning today." She went, "Yeah, it's really busy." He went, "No, it's actually burning down the corridor, and we're going to have to evacuate everybody." So the hospital is built in a kind of a long axis, and the plant room is right beside the crossroads, the entry to all the wards, the entry to the library zone, the residence for the junior doctors.
Yeah.
The residents. And the plant room is just at that corner. So it took out the communications to everything. The power was gone, the oxygen was gone. The access to those wards was going to go, so they made a decision fairly quickly to evacuate before they couldn't evacuate. And we had, for the first time in the history of the state, a complete hospital evacuation. So we had 225 patients here that day, and we evacuated 187 or 188 in total. It was challenging because we have three ambulances in our network. So we had to pull in ambulances, buses, vehicles from all around to try and get people into the nearest hospital, which is 60 miles away. And that itself is a challenge. So it's eerie when you look at it. That morning, there had been an interview in the paper. We've had a business case been rejected by the Department of Health for quite a while or put on the long finger for a hospital expansion of 100 beds. And the quote in the newspaper that morning was, "It would take an act of God for that thing to be built in my lifetime." Well, that afternoon we had the act of God. And if you walk down into that area, I'm going to get pictures another time to share. Offices completely burned. The residence room is completely burned. And the chapel in the middle of the whole thing, not touched, not even smoke damage or water damage, in the middle of everything. So yeah, there was an act of God in the whole thing. So we're now down to 53 beds. We've reopened for maternity services because the next hospital couldn't cope with the volume of maternity that we have. So we have maternity services, we've pediatric oncology going, but the rest of it is all out. The ED is closed. People walk up to the door, we assess to see if you're in extremis, we're going to do something. If not, you're into an ambulance and you're going off to another hospital. And the big hospital down the road didn't realize how much work was done in the little hospital, and they got very upset and then demanded all the staff the next day. So we've been ferrying up staff every day to staff their hospital.
Place was that over in Cork?
Waterford.
Waterford. Okay, got it. Yeah. Okay, got it. Oh, wow. Okay, yes. Appreciate what we do for you.
Yeah. So I mean, all the ambulances were going there at night. The nurses were going, how do you get so many ambulances? Well, this is the standard, there's about 20, 25 ambulances every night. And they went, but we don't get that. So we know you don't, but we do.
Anything happening on the political end that would be helpful or harmful?
So everything, the following day, the various ministers and the Prime Minister came down and they made pronouncements that the hospital is secure. They're going to do everything in their power to bring it back to as it was. We've been investigating everything we can do to try and get short-term modular build, but it's going to be 4 to 6 weeks before we can get 60-bed units. We have a French company that are able to provide a deployable modular unit. It's hard to describe it. It kind of expands outwards, and it would cope with outpatient services and maybe some of the day case surgical service. So we really have to be a little bit innovative for the next couple of weeks to try and figure out how we're going to survive in the short term and ensure that the place gets built back to the way it was.
Yeah. Oh boy, I just can't imagine. It was bad enough before this happened, so it's just amazing. So what can I say? We're all with you, and you got our prayers and so on. And so thank you so much then, Mick, for what you do. And then Mick, I assume you'll be able to come to for the week, right, with us in Fort Lauderdale?
I haven't got the permission yet. It's my 20-year anniversary of my sentence. So
Okay, got it.
Yeah.
All right.
my life sentence.
Okay, well, will I be able to see her, by the way, when I come in May? I got it all set
Yes.
up.
Yeah. Everybody's going down to Killarney, so the whole family will be down there.
Oh, good. I want to see her then. Okay, fantastic. Yeah, I'm going to get in on May 5th. I'm going to hang out for the weekend with my various, whatever, cronies, so to speak. They're in Dublin, and then I'll head on down. I guess I'm going to come down on the evening of the 8th, right? So I hadn't heard back from that person that we had talked about before, so let me know. I do
Okay.
want to, just deal about the hotel down in Killarney. Hey, so one thing I do want to give an acknowledgement to is that picture that showed up on that ACEP Now thing where they were talking about my involvement in mass gathering medicine. What was kind of cool is that picture, I don't have any pictures of me there doing anything there and at these different things, but Mick was great enough to take a picture and send it off to me. So I used that. I thought that would be a good one, since showing me standing by the stage when they asked me for a picture. So I just want to make sure he gets credit for it, because I didn't see it in their article about photo by Mick Malloy, but at least we'll make a public disclosure here. So
Do I get free ACEP membership for a year or something? No.
Yeah,
How does that go?
how about let's ask Sandy, because I think she put them up to this is what, right?
Oh, and I have to thank Sandy and Chris Kahn. We all got support messages today from ACEP, which was fantastic.
Okay, good. All right, hey, Sandy, so let's then move over to you from ACEP. What's going on your end?
Yeah, I just want to let Mick know that he can get free membership with, but the tax is going to be like $1,000. Just in case, or you can just bribe me and I'll the 1,000 and I'll put your name in. Anyhow, a couple of things heading. I know that Mike Levy was talking about their advocacy stuff. Our advocacy meeting is coming up May 1 through 3rd. Please come. We're going to be talking a lot about boarding, crowding, and you guys are terribly affected by that, not only in the EMS world, but when you work in the ED. So that's going to be our number one priority. I suggest you register early because there's a substantial discount, and you'll pay substantially more if you decide to wait until after the secret date of April 15th. Did I mention that April 15th, the cost goes up? You're not supposed to know that. Mike also mentioned the Department of Transportation's new project. We are actually meeting, ACEP is meeting with them later this week to talk about what we in emergency medicine have to do with safer roads and post accident care, as well as injury prevention. So I'll let you know how that meeting goes. Any of you who may be interested in brushing up on your pediatric skills, our pediatric meeting is now virtual. It's at the end of this month, I believe, March 30th. So there's no excuse you can't attend. And when I'm mentioning meetings, we're already knee deep in planning ACEP 23. So I hope you all have it on your calendars to come to Philadelphia. It's going to be amazing. There's going to be a lot of we're really looking to revamp this. But if any of you want to have meetings or anything else going on in ACEP 23, we are going to actually be closing the books on this one fairly soon. So get word to us right away. Oh, one of the things we're going to do, by the way, is have a residency reunion hall. And we're just going to have a whole series of rooms with each residency, hopefully having their reunion there. So you can go from the place where you trained to the place where you worked, to the place where you worked after you got fired from the place you worked, those types of things. So please, again, it'll be great. Another thing I wanted to mention is you may have seen that the DEA came out with new rules. One of those is the fact that anyone can write for buprenorphine. All of the rules around that are gone. But another thing, not as connected, but some people have tried to connect them, is you're now going to have to take an 8-hour course in order to write any type of scheduled drug. Schedule 3 or Schedule 2 drug. So we're fighting back on this, obviously. We also have teamed with ABIM to say if you're an ABIM certified physician, up to date on your MOC, all that kind of stuff, you don't have to take that 8 hours that is contained within our training. But we'll see where that goes. I'm not holding my breath. It's the federal government. I mean, and they're crazy. And speaking of the federal government, you may have or may not have seen a very interesting court case in the federal court in New Hampshire, where the hospital sued, saying that the fact that they couldn't get rid of or couldn't admit mental health patients out of their ED was restricted their Fourth Amendment rights. Now, the last thing I am is a constitutional person, and I don't quite understand how this happens. But basically, the federal court ruled that it was unlawful for hospitals to have to board patients in their ED. Now, some people sued in the past for the infringement of their own right for holding patients, but this is, I think, the first time where the hospital has sued and won. So we'll see where it goes. I don't think it's going to go anywhere, but we'll see where it goes because it certainly is fun. And as you know, boarding is our #1 issue for this year and probably every year until we fix it. That's all it is.
Okay, I have a question for Corey. Corey, is the Fourth Amendment honor thy father and thy mother? Is that it?
I think it's actually assume the worst.
Assume the worst. Okay, got it. So, great. So, any event, so what can you say, right? It's just, you never know what's going to happen next, right? Yeah, anyway, so I hope that it does prevent any illegal searches and seizures at our hospitals for sure. Let's pop over, and I want to try to catch up with a lot of people on the call here today, including you, Joelle, and so on, and some of the others, and Kevin over in California. But let's first go over to Jim Augustine. And Jim, anything to report on from your end, either with IAFC, IAFF, or you, or as you're the medical director now over in Fort Myers and Cape Coral, right?
Yes, I am. Thank you very much, Paul. I put the CME for the Eagles and the Seagulls both in the chat if you haven't seen it already. The IAFC is planning for a big FRI celebration this year, August, in Kansas City, Missouri. It's the 150th year of organization of the International Association of Fire Chiefs.
Yeah.
So they're thrilled with their history, and there will be a celebration that includes activities there. Trying to get more involvement, Paul, of the medical directors, and that's an opportunity in the future. You're working so hard for us at FDIC, and thank you for doing that.
Yeah.
The chiefs of police, as you can imagine, is also very busy, and they're crossing over into so many of our programs now, including our mental health and Narcan and defibrillator and other programs. So nothing like the opportunities of getting the whole public safety force in front of medical emergencies when they occur. Thanks to everybody for filling out the surveys. We had kind of a bolus of them going through, and that's it, Paul. Thanks very much.
And make sure you go through Jim sometimes. And the other thing I didn't want to, especially since it involved myself, was all those emails that go out, that if you or something, we congratulate somebody or whatever, like we did with myself or with Ron, is that you're not necessarily, unless you think it's really important, is not hit everybody else up so that we're all replying all and getting 100 emails from that. But I think the majority of you did that, and I appreciate it. And the other thing is, make sure if you have a question, that you go through Jim so we can kind of filter this a little bit and not have everybody hit up with something left and right, which I would appreciate that. Okay. So, and you agree with that, right, Jim?
Yes, I sure do. Happy to help anybody up front and make sure that the process runs well and that we keep it efficient for everybody in the Eagles.
Yeah. Okay, good. All right. Well, thanks a lot. All right, good. Anybody have any questions? And by the way, I think I'm going to a meeting with the fire chiefs. I think it might be Metro chiefs in Columbus. Does that sound right? In June, early June? Does that?
Yep, it does.
Yeah, I've been asked to speak there, so I just wanted you to have a heads up on that in case they're going to be there. Okay.
Good. Okay.
Yeah, Columbus. Then let's just run over to Rob Lowe. Anything to report out of Columbus?
Fairly status quo here. Just working through a couple of RFPs. Time to redo our call taking software and dispatch and some stuff like that, but fairly status quo.
But then,
Hey, Rob Lowe, did you know there's another Robert Lowe, MD, MPH, in Oregon, who commented yesterday in an Annals or in a JAMA article about the recall, the Philips recall?
So I have never met this person, but we have gotten mixed up before.
Yeah, Paul, I saw it and I thought Rob Lowe is really broad in his applications, and it was a fake. It was a fake. Another Robert Lowe, MD, MPH.
He's an actor. He's over. It's just he's unbelievable. He's all over the place. So, hey, so when you said about the Philips recall, what was the Philips recall? I don't know that. I guess
this was their CPAP machines. And it was disintegrating and pressurizing particles. That's a really big issue for the FDA. So that's the recall they're talking about.
Betcha. Sounds like it. Wow. Okay, got it. All righty. Well, thanks. Joelle, you still there? Oh, by the way, Rob, if they don't make me go somewhere else for dinner, then you and I we have to go up short north to Marcella's, right? So we got to make sure we get up there, correct?
I'm always good to eat. Let's go.
All right, good. All right. And then a little bit of graders after dinner, right? So, hey, let's go up to Joelle, are you still here by any chance? Or
I am. How's it going, Paul?
Great. Okay, good. Well, we missed you. So we just want you to know is that we're going to have the SWAT team respond this year to the Hard Rock. We're going over there.
I'll tell my husband to be prepared.
Yeah, it's good. So, so what's up on in San Diego land?
Sorry, I was not thinking about updates. Sorry, nothing too huge. We're still trying to handle the volume that we have. Our hospitals are overwhelmed with boarding patients. Yeah. So we're fighting the offload times, which I think everybody's having that same problem. And it's just not getting any better. And we're continuing to fight for that. And we're getting our lifeguards up and training and ready for the summer season in San Diego, which is always beautiful. Yeah. And nothing else huge right now. We're just trying to stay status quo and get our research going and projects going and not break anything for right now.
Well, when you say your research going, what research are you doing?
Oh, we are trying to set up a study, a research system in California, because we have so many large metropolitan and rural area provider agencies, that California would make a really good area to do research. We already meet, we collaborate, we do stuff. So we're actually trying to create kind of like a California rock group. Good. And see if we can do some high level research. Kevin Mackey and Clayton Kazan are also on that. And it turns out to do an NIH grant, it takes about 5 years of prep work. I did not know this. And so we meet every week to talk about this.
It's probably more than that sometimes. Yeah, it's amazing. So,
oh my gosh, I have such a new appreciation for everything funded by Rock and how long that must have taken to set up, and let alone to actually enroll patients with.
Well, and then the downside for me is that because I helped get it started, and particularly they didn't even have trauma involved at first. And so I was very fortunate because my boss at the time was the president of the American College of Surgeons. So we're able to leverage that. And it was, it took forever. You're right. And then there's going to be disappointment. So, because you got to herd the cats in a lot of ways. So it'll be interesting. So good luck with that. But if I can help out anyway, let me know. And, it's going to be great. And then I assume you're going to be coming this year, and do you have any topics that you want to go over or think about those, and let me know. Okay.
Awesome. Will do. Thanks, guys.
All right, good. Let's run up, I guess up I-5 and then head over to Sacramento. Anything to report, Kevin, now that you got your name mentioned there?
Hey, Paul, thank you. Biggest things going on up here, Joel talked about the APOT times, which is our ambulance patient offload time. We've put a dollar figure to it. One of our local fire departments has actually begun to bill the hospitals, which has created a bit of a stir and a controversy. So I'm in a new role. I took over as the county EMS agency medical director about a month ago. Yeah, I'm that guy. So I unfortunately have had some uncomfortable meetings with some leadership of the hospitals.
Yeah.
And I've actually developed right now it's at 7 steps, a 7-step plan to addressing wall times. I just want to call out and acknowledge Ken Shepke. He really, I know he's not on the call anymore, but he really helped me understand how they address this in Palm Beach. And a lot of it was really what I'm calling turning on the lights. I've been meeting with some boards of supervisors and some county CEO leadership and just enlightening them about this. And we've actually just about an hour ago, we've been able to develop a 72-hour rolling dashboard, which shows each hospital and percentages in the times that they have wall time issues. And all we're going to do is just turn it on, and so that it's a forward-facing dashboard. And Ken said that was very effective in Palm Beach, but that's only step 3 of the 7-step plan. Each step down the line will get less and less comfortable for a hospital CEO. And it's not a step I want to get to, but it's one that I'm willing to go to for the benefit of our patients. So that's probably the biggest issue we're dealing with right now.
All right. So a couple things I was thinking about when you were bringing this up, and then I saw the post right now just by Joelle, is that Joelle's missed some of these meetings where we have talked about this, but that will be a really great topic to bring up maybe during the discussion, because I think it's of national interest. But one of the things that was really cool is that people not only had community paramedic programs, but we're actually even targeting a spinoff of that, where we're looking at doing hospice and palliative care, maybe having a certain, let's say, segment of our folks or our community paramedics doing that. And because we're finding out about a lot of revocations of people's hospice status when they call 911 when the family's panicking. And so there's that may be, I think, a new golden area that we're going to be working on. And so we're going to have a whole session on doing this. So I just want you to be aware of that. Okay. So by the way, and I'll use that as a nice segue, is that a couple of things that I've accumulated so far was that everybody wants to talk about triage, right? Are you using RAMP? Are you using whatever, right? And so we'll talk about those and the pros and cons of adopting that and helping each other out along those lines. The other one was, do you do CPR? Do you do chest compressions during, in other words, for trauma cases, right? Which is, that was really interesting, that everybody's still doing it, even though we can't figure out why we're doing it. And so I think it'll be kind of a cool debate. And I may bring in a couple of surgeons actually to add into that, that vein. So I want to thank Ben and Weston for both of those topics that we just discussed. And then the issue is the pros and cons of statewide protocols. And I thought that was a cool idea that Jeff Jarvis brought it, that it wouldn't work very well in some states, and it may, I don't know, as what David Miramontes once said, may even stifle innovation, et cetera. So whereas it actually may bring up the standards and others. So it'll be kind of a cool debate. The other one, we said hospice and palliative, and then the issues of mass gathering, people are interested in this, and then tiered response. And of course, the most important talk would be one about the benefits of chocolate. Okay, as I saw, it was submitted to me. It's kind of funny. But I am going to add in a couple other things that I heard today, as a matter of fact, about the impact of legislation and how we're going to deal with that, as we've heard, and so on. And I think that'll be and the antibiotics things as well. If there's any other topics that you want to debate or talk about, please let me know that. Okay, so. Alrighty, so let's move around the country a little bit. Let's jump over. We usually kind of unfortunately never pay attention, unfortunately, to sometimes the Florida folks enough, because I know what's going on there. But if you don't mind, Angus, anything you can tell us from the state of Florida, or at least from your region in Tampa?
Sure. So I am just back from a couple of weeks out of the country on vacation, so I don't. Which was amazing.
And you got any restaurant recs for us?
Yeah, I went sailing in the British Virgin Islands. So
nice.
Yeah, it was fantastic. So we have we managed to do a lot of things while I was away. We burned down an ambulance and the car wash it was in. We made the national news. I'm sure some of you read about us in GEMS and NBC and People magazine even. So we managed to do that pretty well. And a few other bits and pieces that have kept me busy for the first day or two back in the office.
What did they say in People magazine? People want to know. Inquiring minds want to know.
It was the same news story that was everywhere else about a misadventure of one of our crews.
Yeah, okay, got it.
So, yes, Kevin says his son is one of my new paramedics, and that is true. And it was not his son that got in trouble or burned down the ambulance. Thank goodness. But his son is doing very well here. So I think the most interesting thing right now is one, to Kevin's comment. I know it's heresy to say in this group that doesn't believe in hospital divert, but I maintain 95 to 97% 15-minute or less drop time by using a very active management strategy that includes EMS initiated bypass, hospital initiated divert, dashboards, public facing metrics, et cetera. So I'm not willing to totally sign off them actively helping to manage the status of the system. So I think that's still an interesting point for discussion, but maybe more interesting is the presentation we had on the Florida meeting today, with a really great discussion about online medical control methods, who does it, how they do it, whether they record it, whether there's value in recording, and whether the concept of a high-risk refusal is even a good concept anymore. So that was a really interesting discussion, and I think could turn into an interesting paper maybe if we surveyed folks on what the practices of online medical control look like across the country. I think there's some disparity there, and maybe some interesting things to learn from that.
So what I'm going to suggest is that we do that during the Fellows Day, the second day, right? Because some of those fellows do that online control, or they were residents who did online control. And I hope Ray Fowler will be along. He actually started a really cool program. His requirement was that before the residents got on there, they had to actually not only take a kind of a course about how to do it, but they actually had to be in the streets in terms of seeing what those guys are going through. And Peter, you brought up an interesting point once about, because we were talking about this, is that sometimes when you call someone at the hospital, they have no idea what you do, and they go, just follow your protocol or whatever, right? And that doesn't, that's not why they were calling, right? They were calling because they wanted some extra help, right? Do you want to mention that?
Yeah, I mean, this is for years before I became a medical director. It was, you call the hospital and you get some random ED doc who just said, just follow your protocols, and it would really frustrate our paramedics. And so we've completely changed that, but I really think that people like Angus are really dialed in. Mike Austin in British Columbia really dialed in. And so I think that we could, I mean, I know that I could do better with, as far as recording, documentation. Is this a legal issue or a quality issue? There's so many things that go around this. If you think that the high risk refusals are the highest risk for us, I think that not recording things just doesn't make sense.
Yeah. Because this is what my point was before when we talked about the body cams, that you could have this thing and the guy doesn't want to come, and then whatever, you get the whole vibe of the thing, let alone the fact that then later the guy dies and the family sues you, and so they weren't there or whatever it may be. To have that documentation one way or the other is really important. So in any of this stuff, that kind of thing. So that's really, really great. So there's more to it though than just, my point is that there's more to it than just a high risk, whatever. They're calling for help because they're, because you just follow your protocol is not why they called in, right? So that's part of the important point that we got to get across. So thank you, Peter, for that topic. So it's good.
I'll say to that, Paul, one of the things I'm most proud of in my system is that we provide our own online medical control. We don't rely on any hospital-based docs. So we have our own group of doctors. They are part of the system. They are assigned in-service updates, just like the medics are. And about 2/3 to 3/4 of them are fellowship trained, board certified EMS docs that are on the other end of that radio for the crews 24/7.
And David Purse, are you still on, by the way? Because you started going that direction, right? You have a base station, and they're actually fairly sophisticated people there. Some of the firefighters who are like injured or whatever, right? And they can connect you and give. But tell me a little bit more about how you're handling, because you guys take calls from the field. Don't you have someone on call at a different? I don't know if David can hear me or not. Are you on, David? No, that's fine. We'll catch up later. So David and Percy, if you come on back again, we'll have you talk about that. So the Ron Roth is not on because I know they actually have the residents respond there in Pittsburgh. So I was just trying to get that.
Yeah, actually, I went to that residency, Paul. So I can tell you that, first of all, in the state of Pennsylvania, you have to take a class to get your medical command certification to be a doc doing
Same
consults.
thing. I remember I took it, right?
Yeah.
Right.
And then you had to go do ride time with the medics and in your own response truck before you were sort of assigned an MD number for the city as a resident.
Right. Yeah. Yeah. So those are good topics to all bring up, and those different angles are really pretty good to bring up as well. So I like it. You know, I actually got to go with Ron Stewart, you know, back in early 80s. It was kind of fun and watching how that all played out. Okay. Pete, yes, Peter.
Just the other side of that coin, and we discussed it earlier on the Florida call, is whether the paramedics need training and, you know, more CQI on how to call the medical director and how to present the case appropriately. So that's another good side of that argument.
Excellent, Peter, and make sure you remind me of that when we put this together. So I like that. That's a really good point. So whatever, Peter, you take call in a couple of different systems on certain days, right? Do you get hit up a lot, or do you think they just not used to calling doctors, or what happens there?
Yeah, on certain days, Monday through Sunday, every day. It's actually, you know, it's actually the favorite part of my job. So we, you know, we're up to about 2,500 paramedics. They all have our number. I personally get more phone calls about their personal problems than about the actual medical problems. I try to inspire them to call us more often. So I really try to push that, but I find that you get the same kind of group of people who always call you, and then everybody else doesn't call. So I'm still not sure what it is that creates that trust, but I work really hard at that part of it. But I don't have the answer per se as to why some people love calling and some people just are scared of calling or whatever.
Yeah, and it may be just tradition or what they're used to, or they've been around for a while, or you know, whatever, and they don't want to bother you. They think you're busy, and it's all sorts of things like that.
I think that's probably what it is, because everyone who calls me says, "I know you're busy,"
right?
And I said, "Well, I'm talking to you. I'm not that busy, you know."
Yeah.
But I think that's probably what it is people are worried about bothering me.
That might be a good thing to bring up as a discussion with the audience itself. You know, I think that one of those days. Yeah, we'll have a talk on it, and then we'll have the audience react to it and all that. That might be a cool thing to do. I like it. All righty, so let's do. There's a couple different angles I want to look at. I'm going to go to Glenn in a second, Glenn Asada, to say, well, how do you do it in New York? Because it's wild there. You know, it's a little bit busier than most of our other systems. But Stein, bring up the issue first about Pulsera providing medical command. What do you do?
Yeah, so we use Pulsera for all of our pre-hospital communication to the hospitals. And during COVID, we asked Pulsera, can you give us like an immediate way to talk to and video with our paramedics? And so COVID was really the impetus for that. But it turned out to be one of the best things that we ever did, and that turned into our medical command for the paramedics. They used that anyway to communicate when they're sending patients in. They can just open up the app and press on a MD consult button, and it goes right to whatever EMS doctor is on call. And so we'll answer it, 24 hours a day, 7 days a week. Monday through Sunday, like Peter was saying, and we just share it among all of the EMS directors so that they're not calling into the hospital and getting random advice from people who don't understand their scope. And we can video it, we can do video, we can do audio, and there are ways to record it, although we don't systematically record the conversations. And so I'm glad you guys brought that up as something to consider.
Yeah, I just was at a really kind of a cool meeting where, you know how the trauma surgeons have often videoed their stuff in the trauma room as a QA thing. I was just at another presentation where they're doing it in the streets, looking at how people are doing the blood in the streets and so on. And so it's becoming more and more of a thing, because someone else is going to be videoing you anyways, probably. But it's, I don't know, it just, there's, let alone recording, like an audio recording. So I think it's going to be interesting change as we get out here, but I like what you're saying here, but I see things evolving here. So this is a good discussion. Thank you so much. Glenn, what do you, oh, go
Sorry,
ahead.
Paul, I was just gonna ask if there's anybody on from Illinois. I think there was a thread on the state medical directors on NASEMSO that there's a piece of legislation introduced in Illinois requiring body cams for EMS.
Yeah, that was brought up earlier by Mike Levy. He brought
Okay,
that.
good. Sorry, I had to step off.
But what he said was, or someone else made the comment that it always gives us heartburn when they require it, as opposed to us, bringing it on, and then it just, this whole trend where they're going to legislate how we practice, that kind of thing is, or do QA is a little bit concerning. That brings it up. Let me run over to Glenn real quick. And Glenn, you must have a lot of requests. And do you have a medical control, and who does it? Are they people that know what they're doing when they answer the paramedics, or is it, how does it work in New York? You're so busy there.
Yeah, to go with our call volumes, unfortunately, we do have medical control. So we have a regional exam, a course in an exam to become an online medical control physician. So you take the 4-hour class, you take the exam, you pass that exam, then you sit with an on-duty medical control physician, and then you get a credential from our regional council. That allows you to work in the online medical control center. We are one of 4.
Let me interrupt you. I want to make this clear. Most people think of the medical control center being at a base or something at a hospital, and sometimes individual hospitals, let alone a center. But like David Purse, and I think in Dallas as well, you guys have a actual medical control center that people can go work at, right? Are they paid for that position and so on?
That is correct. So the physicians, our online medical control center just moved recently to the PSAC 2 location in the Bronx. So it's in the most modern building that they have now for communications. So we have paramedic staff, supervisors, and 1 physician per tour for 3 tours a day. So just like everybody else, after they exhaust their protocols, medical control, also destination decisions, anything such as STEMI calls, LVO, they'll discuss with the physician to redirect them to these capable facilities. Right now, we're looking at potentially trying to get to ECMO capable centers. So that's a pilot we're looking at. We're doing about 60,000 calls a year. The physician is paid, but the rate is very low, as with everything in the city. So I have difficulty trying to get somebody to man these positions. But currently it's 1 physician. When we thought ET3 was coming a little bit stronger, we're trying to petition for a 2nd physician because that staffing model has not changed since I've been here in 25 years, despite the fact that the volume went from 40 something to 60 something thousand now. So it's pretty challenging. Everything is recorded, and we get calls for anything, drug tracking and things like that, destinations, refusal of medical aid when there's a high index suspicion, things like that. The other 3 centers do have medical control where it's hospital based. They are doing medical control for a lot of the volunteer EMS agencies. Sometimes they'll do medical control for their own 911 units that come out of the hospital. But we do require that all cardiac arrest, all LVO, all STEMI go through ours for accountability of QA/QI, and just to keep track of everything that's going on in those cases.
All right. So I want to say that there's a lot of different models out there, and it'd be interesting to learn from each other and, maybe either adopt whatever somebody else has or modify accordingly. Because obviously there's pros and cons to what you have. There's a lot of pros to it, but then again, the cons are, does everybody have to travel up to the Bronx then? That's another issue, right? So
they do, although after COVID, some physicians were afraid to come into the center. So we actually, for tour 1 overnights, we do have the possibility of remote where they can take it from their home. But that only works at night because the volume is a little bit lower.
Yes.
It doesn't work during tour 2 and tour 3, just not possible.
Yeah, right. And tour 2 and 3, when is tour 1 start?
So we recently switched it. So tour 1 starts 10:30 p.m. to 6:30 in the morning, because when we switched to the Bronx from Queens, traffic was just much worse.
Yeah.
Tour 2 starts 6:30 to 2:30 in the afternoon, and then tour 3, 2:30 to 10:30 p.m.
Is there a time zone differences at all? So, just kidding. So, but you know what? Speaking of which, that's a good point. Just make sure everybody's aware we're switching the clocks this weekend. Okay, so 2 o'clock they'll have a shorter shift that day, right? Because
right.
that's right. You'll be up a little earlier the next morning than you
This
thought.
is a good one to get paid, but allows you to try to sleep that extra hour.
Exactly right. So, all right, good. Hey, Joe Holly, are you still there?
Yes, sir. Hi, everybody.
Yeah, you were bringing up the issue in the over the chat about the SGA research. This is a supraglottic airway research project, and what's that about? Just the FYI. And Scott,
It is just the 30,000 foot view is that Rob Dunn and I and some additional collaborators sort of looked at the latest versions of supraglottic airways, repeating the study that I'd done about 5 years ago and reported it to Eagles. Just looking to see which supraglottic airways were best at maintaining a seal during CPR and that sort of stuff. So we're happy to share that data.
and if you look at it with mechanical devices as well as a pair of hands.
This was almost exclusively mechanical CPR.
Okay. And
fresh cadavers too, which was
That's correct. Thank you, Rob. Yeah, on fresh cadavers.
yeah, okay. And did you compare whether you did, it was just the machines and you didn't compare, for example, the plunger device, right?
It was a Lucas device with the 1 inch, 1 centimeter of lift to it. So not aggressive active compression decompression.
Would you like
But
to
we
talk
were-
about it at Eagles, or you want to talk about it now, or what do you think? And then
Oh
Rob-
no, we could save it for Eagles. I just want to throw it out as a topic for Eagles.
We all want to know, especially after Frasconi, RJ presented that thing about when they were using the iGel, they were getting leak around it while they were using some. So we'd like to know about that. That would be really good, especially if it's done, if CPR is being done right, does it cause a problem on that end? That would be really good. And it also raises the issue of maybe when and how you deliver the breath, which we've talked about before, especially with Keith. So that all that will be cool. Well, thank you so much, both of you. Then Rob, you wanted to talk a little bit about your mind rhythm project, right? Can you talk about it now, or you want to present it there, or what do you?
I can present it sometime. I've got some slides. I don't have them right in front of me this second, but we've got the data from the first trial is out. We presented at the stroke meeting. We're in the process of writing it up now, but I thought people would be interested in well into the pivotal trial by the time we get to Eagles. So
if you want, give me a heads up like on Monday and said I could present it tomorrow. We'll have you do it. If you do like a 5-10 minute thingy.
yeah, 5 minutes.
Yeah, good.
Or less. 5 minutes or less.
Yeah, just remind me just before. Yeah, the only thing I need to do is just remind me like on Monday, and I can put it in as part of the thing. Okay, which is good. I always sit there and go, hey, I need more topics here, but we always seem to cover things, right? Someone just asked me for a list of the topics that we go over. I go, I have no idea what they are, because they just pop up like this. This is fantastic. This is what I love about our discussions. It's really cool. So it's good. All right, sounds great then, Rob. Good to see you. Anything else to report out of Detroit since I got
just a couple quick things. We're having a meeting and a presentation about some nurse call lines. I want to thank Bob Holman specifically, call him out on that. I'd spent a bunch of time talking to him, bugging him to call them there to talk about theirs, and at least to get this in front of my leadership here, because I think there's some of the same things we could be doing on that. We've been doing a lot with mental health co-response using our EMS data to really drive some change. So it's finally good.
Before you go to that, have you been to Rob's Center in Washington? If you're ever there, you should go see how it operates. It's kind of
we'll definitely go there when I'm down there. he invited me to come down there. So
health thing. Sorry to interrupt you. Okay, go
yeah,
ahead.
no, that's great. And we've been having a discussion about centralized medical direction as well. We've got the technology. We're kind of working on the docs and how we're gonna pay them. We have a good critical mass of physicians all kind of affiliated with our fellowship here in Detroit, because we're ready to move to that. My medics are where Peter was talking about, they get the most useless advice sometimes depending on who answers the radio. I mean, we've got a lot of smart people and a lot of good people. We've done base station classes and stuff, but they still get that, oh yeah, follow your protocols. It's like, okay, you idiot, I wouldn't be calling you if I was at that, if this met some kind of protocol. So
One of my greatest advices I could give is actually have them out there doing some ride-alongs first. That's what we do with our residents before we let them use the base station. You got to see what they're going through now you can relate to it better because you physically have seen it or understood it or had experiences like that while you were out there. I think that would be really
very
good.
variable what people get out of their experiences. Let's put it that way.
And then
It's funny, I'm sorry, in New York City, sometimes it goes the other way where our telemetry doctor tells the medic, keep warm and transport and no other further orders. So it can go both ways.
That was one of the best things I learned at FDNY's telemetry was when you thought the crew was really no clue what was happening. You say IVO2 and monitor and call me when you get to the hospital.
That's great. So anyway, that George Hatch, let me bring in you because we found the same thing that I just mentioned when went to paramedic school. If they hadn't been an EMT for a while, they didn't do as well in paramedic school because it was more abstract versus you could relate to the situation that you were learning about because you had been out there, right?
Yeah, absolutely. And a lot of those people I remember in those first few cohorts of classes that we had in the early years were people that were long tenured EMTs that, volunteered to go to paramedic school. They weren't forced to go. They actually wanted to go. And you were able to pair them up with, preceptors that had a passion, or if there was a weakness, if you will, in a certain area, that person could then be directed to a Burt Withers or a Jerry Rhodes or a Dwayne Marriage or any of those guys that you had identified early on. So yeah, I think it made a difference.
I'm just saying is that it's the same thing, in my opinion, applies to this when you're going to be doing medical control. You got to have a physical, you've had to have experience out there to be able to do a better job of learning, in the classes that you were talking about there, for I guess, for example, in Pittsburgh, and so on. So let's do this. Well, George, do you have anything to report from COAMPS at all?
We're still moving along. We have a town hall meeting scheduled for next week. So if folks, still have an interest in continuing to participate in the dialogue, we're still there. We have a workshop tomorrow. We have 60 participants. Of those 60 participants, I got to tell you, there's 14 people in that class of 60 that are thinking about starting a new paramedic program. We're close to 800 paramedic programs right now. So I'm not really sure where they're all coming from, but they represent everything.
Are you worried about quality, or do you think you have a good system that the quality is going to be good?
Well, I think I'm always concerned about quality. The accreditation process is really driven about looking at resources and outcomes. And I don't care if that's you guys being physicians or if that's somebody learning to be a paramedic. It really is looking at their outcomes. So our focus is looking at how do they do on the national registry exam or their state certification exam for the 1 or 2 states that are still using it. Do they get a job? And how many people do you start and finish with? Attrition and retention. So those are really the outcome measures. If they can't pass the test, then you have to start thinking that there's a problem. Raw material, people that are teaching. There's a variety of reasons.
I want to come back to Terry in a second. I want to hear from Scott Gilmore because I hadn't heard from him for a while. But Terry, I'll come back to your comment in just a second that you put in the chat. Hey, Scott, anything we need to know about from anything you need about from St. Louis? Scott, are you there? Scott Gilmore? Guess not. Okay, got it. Well, it's too bad. Or else I can't hear you at any event from if you're trying to pop in.
Can you hear me now?
Yeah, now I can hear you.
There we go.
Now I can hear you. We can even see you, which is even. Hey, before you go on, remind me, what's the dates of our meeting in St. Louis?
October 5th and October 6th is the actual thing, but October 5th when you come in the day before, and I'll try to feed and water you.
We're not going to go to the Hill this year, though, right?
Probably going to go to another Italian restaurant out by the hotel.
Sounds great. Then I'm looking forward to it. Okay, so anything to report out of your jurisdiction?
Nope, just facing the challenges that everybody else has. Right now, unfortunately, we have issue with retention. I was going through and doing the yearly stats for my department, and 60% of my paramedic positions within the department are vacant.
Wow.
Whoa.
Yeah. So
you may want to end up talking to Jeff Jarvis and Goodlow and all those guys, because that's how they got around it with the reconfiguring the system. They turned out to be very, very happy with what they're doing. So we'll talk about that off.
I've already started using the usual BLS ambulances and from dispatch, all that stuff. So
They're all coming to Florida, Scott. They're all coming to Florida.
there you go. Actually, no, they're going to my urgent cares down the street where they're getting paid $52 an hour to swab somebody's nose for COVID.
Oh, wow. That makes sense.
What's COVID? What's COVID?
Yeah, exactly.
Yeah, they are most definitely not coming to Florida because I'd hire 100 of them right now if I could.
Yeah.
I think they all came to the other side of the state, Angus. Just saying.
So Terry,
Well, they chose poorly then.
hey, Terry Valenzuela, is it okay if I reveal what you put in the chat?
Sure, go ahead.
Anyways, what Terry was reminding us that it's that when I first when I was in Seattle and I started visiting around to different EMS systems, people would say, we've got 62 protocols or we have 109 protocols. And all I could think about is we only had 2 protocols in Seattle. And my twist on this, Terry, was that 1, the way COPUS wants it done, and 2, the way COPUS doesn't want it done, right? Those are the 2 protocols that you needed to know. It was simple as that, which is good. So anyways, I'm going to be coming up there. We're going to have a memorial. I don't know if you're going to try to make it or not, but we're going to have a memorial for Dr. Cobb, by the way. And I'm going to hopefully go see Mike at that time in May. So just be as an.
I need to know when it is, Paul. I'm waiting to hear when it is.
Yeah.
Yes, I'm coming.
The memorial that they're going to have for Dr. Cobb is going to be and somewhere maybe at the university. They're trying to figure it out, but I think it's going to probably be on that Friday, and then they're going to have a 50th anniversary, even though it was delayed for Medic One. I think on that May 13th. We talked about it last week, but I'll try to get you more data later on. Okay.
Okay.
Thanks. Yes, go ahead, Peter.
Yeah, I just wanted to just address and see if anyone has any comments on this, but regarding why medics leave one agency to another. And, you and I now with Brevard County recognizing that if there's a disparity in salary, the medics will start somewhere.
Yeah.
And then get a few years of training, and then they'll go right back. They'll go right to the agencies that pay more. And I think that's a huge issue across the country, and it's a regional issue as well.
Yeah, I saw that really early on in the 80s, actually, in 90s, where they had some of these places that were the systems. Like Pinellas had originally, I forgot there was a name for the Jack Stout kind of approach things, and people would get years of experience in there because they get paid less, and then they go out and become a firefighter somewhere, to get paid more. So it's an old phenomenon, but finding a different way nowadays. So it's kind of interesting. All right.
Because you don't see that much disparity in physician and nurses' salary, do you? That's the issue. And in paramedic salary, there's huge differentials. So anyway.
There's a pretty big differential between community and academic for docs, so it's sort of the same thing.
Yeah, that's a good point.
Peds M and adult EM.
Yeah. So let me go paramedic money. That may be a topic to talk about generically there. Okay, that's good. Let's try to make some rounds here real quick. Since we're over in the Midwest, so to say, let's go over across the river to Memphis. Anything that you can tell us, Joe, that we need to know about either the state or locally there with you?
Things are rocking along. We continue to feel the ripples of our incident earlier this year, with some changes and education going on related to interagency issues, primarily with the law enforcement, of course. At the state level, our EMS board continues to be a topic of discussion in the legislature. It's a bit of a power struggle, tug of war over what entities, groups, and people should be represented on the board. So that has yet to be resolved. And our board is, until it is resolved, our board is set to dissolve on June 30th of this year. I'm sure it'll be fixed by then, but they have prior legislation that vacated the board essentially is set to time out at June 30th.
Okay, got it. Let me run over to Corey. Corey, anything to report out of Nashville?
The only thing I have to report, and I don't know if other people are seeing it in their communities, is the number of hit and run MVCs and the number of pedestrians hit in intersections over the past month is just like exploded here in Nashville. I don't mean, they're dying in the streets left and right, but we've never seen this amount. I'm just starting to see run sheet after run sheet with it.
Okay. Has anybody else seen the same thing, or you notice? I mean, that's interesting. Maybe there's a new trend that we got to be aware of. Is it? Let me ask you this: how about homeless people out there with their signs, or is this just average person out there?
No, these are either pedestrians or people driving within the speed limit, hit by somebody else who's jumped a light, and then they just speed away.
Yeah.
Same big issue in Southwest Florida.
Interesting. So just, it can be just anybody overall. So that's interesting then. Okay, got it. I bet you COVID caused this.
Yeah, it's vaccine. It's definitely vaccine related for sure.
That's what I think.
Well, it's interesting because some of the people have been vaccinated that were hit.
Wow. See, there it is. It was the magnet thing,
It's
right?
because they're magnets. Yeah.
Yeah. Thank you, bro. I'm so glad to hear everyone's thinking alike, who's coming. Okay. So, all right, let's move along here and try to catch it. So there's a name Scott Holman there. Who's Scott? I'm just sorry. That's not Rob Holman, is it? Is there Scott? Who's Scott Holman?
Hi. No, I presented to you the Eagles about a year ago on a technology that we were building out here through Dr. Mackey. And I've seen he'd already signed off.
Got it. Okay, thanks. I just want to make sure I didn't miss anybody or that kind of thing that I usually check on. Okay, thank you so much then, Scott. Let's see, Libby, anything to report out of Hawaii?
No, we're just trying to beef up our integration between mental health and the homeless and the community paramedicine side.
Yeah. Okay, got it. Sounds like you can huddle a little bit with Joelle and Rob at this point in time. That's interesting. Let's see. And John Kramer, anything you could report on, or it's great to have you here.
Thanks, Paul. Nothing new.
Hope you can come to Florida. That's all I can say. It'll be great. Okay. You think you'll be able to make it this year, by the way?
I've got a conflict. I have to see whether we can work it out or not.
All right. Thanks a lot. We'll talk to you later then. All right, David Purse, are you back yet by any chance?
Yep. Sorry. I'm on call for HFD today and it's been busy. Sorry.
It was interesting because we were talking about that very thing. I was trying to call on you before because we were talking about taking calls to talk to paramedics in the streets and all that kind of thing. Can you tell, we may have to bring it up next week, but if you could come on, remind me, and then we'll have you talk about the model you use for talking to the medics on the streets and all that, because I was saying that your session is evolved. You still have a central center, right? Telemetry or whatever area, right? But
Yeah.
you also have your EMS guys taking certain types of calls as well, correct?
Yeah. So, we're in dispatch on 1,200 runs a day. So we're transporting, our transport rate is less than 50%, which I'm not really proud of, but such is life in the big city. But they call in on all cardiac arrest, just as right now, we rarely have anything to change, but if we change the protocol, we find that it takes about 18 months before everybody gets the new twist in ACLS or whatever, which is really disappointing, but we've got to be very hands-on or it just takes forever before they figure out, no, we're not still stacking shocks. We shock once at a time. Or whatever the situation is. And so, but that really the majority of the calls are not the cardiac arrest. It's all of the one-offs, right? It's so like, what I had today is that, the AFib patient that didn't respond to adenosine. Why did we give adenosine to AFib? Right. And, those sorts of things. The paramedics don't understand why the patient's not responding to the drug that's not indicated for the problem. Or the complicated refusal or the angry bystander, the doctor at the clinic who's all bent out of shape for some reason. It's mostly we're dealing with those things, quite honestly.
Yeah. Okay. That's an interesting aspect of things as well. That Peter, if you remind me, if you could put together a little bit of a flow chart of 3 or 4 aspects that we have to talk about. I like your idea, for example, of like talking about the medic side of things, right? When they don't call or do call or whatever, and let alone now we got the third parties and all that. What are the medical director's roles on what's today's role of the medical director in online medical direction? That'd be kind of a cool topic then. Okay.
And I think to add what Stein said is to talk about what what technologies are available for
Yes.
those, for us nowadays, because, you know, we had Pulsera on our webinar last week, and, you know, they've really done a lot of great work, but other people are just using, you know, Google Voice or
Oh,
your
man.
cell phone or radio. It's all over the place.
So you heard what we heard today and you've been thinking about it. So if you could just have 2 or 3 bullet points to talk about different angles, then maybe we could put a session together about this and even a panel that I could go around and say, hey, David, what do you do? Or what do you find? And then we'll ask the audience what they, you know, why they don't call in or when they do call in or what they would like us to talk to them about, right? I think that would be a really good session. I think. You agree?
Yeah, 100%. Yep.
Good.
We'll
And
do
then,
that.
you know, all right. So then let's, I'm trying to think who I haven't caught up with yet here on the call, but we're gonna have to, I am gonna have to get up. Ted Lee, anything that we need to know about from your end with, especially FDIC? Okay, maybe not. Let's see, who else do we got here? George, David, Corey, Colin, let's see, Chuck Burnell. Chuck, anything else to report to from, nothing new from last week, right?
No, but on the pay scale discrepancy market-based pay thing, I have a lot of experience with that. If you want to, I'll be part of those discussions or whatever you want to do. I'll be glad to participate.
It's across the board in a lot of different areas, and it'd be kind of good to know about, like John was just bringing, of course, with the nurses and all that. And then, of course, as Terry's saying, with the police. So it's in every, I guess, in every corner. So I think, is there a way we can help preempt some of the issues that we're all facing now? And what do we do about it? How do we go about doing it? Would be a very cool thing.
And
Stein,
also the Met Control thing, different ways to do that with kind of prioritizing or tiering the calls to the medical director to try to figure out what needs to actually have a medical director, because a lot of, like, I think Peter had something about, or somebody had said something, a lot of the social political stuff that comes through, instead of just receiving all those calls to manage the volume in our size and get the medical director to the medical director calls, we've had to kind of put some buffers in between that. And if you want to, I'll be part of that discussion too.
okay, cool. Good. Yeah, so I was talking about people underpaid. I'm definitely underpaid. I want to find, if you guys have anything for me, let me know. So
Paul?
yes, go ahead, Pete.
Jim is going to send out a survey that I created. I already sent it out to the Florida folks. I'm just curious to see if people have thoughts. We've been having a lot of problems with our monitors. It's giving us blood pressures of severe hypertension followed by significant hypotension. It's both LifePak, it's Zoll, it's all over the place. And we sent out a survey and we got so far 63 responses, and a majority of people are saying that they're having the same problem. And I wonder if there's some fix or something that we're not looking at. So look out for that email.
Bring that up to me and let's talk about that next week. Okay, we want to have everybody on the call because there's only 16 people left here, right? So
right. Perfect.
Maybe next Monday and we'll put it on the agenda, okay, for next week. Okay.
What I'm going to do for the people on the call, I'm just going to put in the results we have thus far, just for people's interest, just so people can think about it. But yeah, we'll do it next week.
All right. Anybody else have anything else to report on? Because I got to get going myself, but leave the office. I'm not the only one left here, I think, in the office. So everybody else cool here then? Anything else you want to talk about? Anyone? Stein?
Yeah, Paul, this is Stein. Yeah, how would you like us to give you subjects to potentially consider? Just email you, or are you going to send out something standardized like you did last year?
I want to try to do that. I think in fact, I'm meeting with Candace in about a week from, or 9 days from today. And we're going to sit down and figure out a mechanism. And I may just want to have you help me with maybe doing a survey thing where you can put it together for me, and then I can, do the printouts like I do usually. So I may try to get this done a little earlier than usual, just so everybody knows what they're talking about. And I'll try to be better about what I do. So, okay.
Okay, sure.
So, I mean, what's kind of interesting is we already know some of these topics right now. Kind of cool. So, I just, it's kind of cool because we're discussing it. In the past, we get together once a year and we go over stuff. It's so cool that this is going on, but we can focus in on it more for the rest of the world as well. And for the fellows, I hope okay. So it sounds good. I mean, I've already got a good idea about some of the things we want to do. So I just got to make sure I know who the players are that would talk to you about each. I can prioritize for each topic. Okay. So, all right. Anything else? Nick, anything before we go? Okay. All right, everybody, then thank you so much. I better get rolling. So thank you so much. We'll talk to you later. Welcome back, my friends, to the show that never ends next week. See you later. Bye-bye.